I have the pleasure today of introducing Dr. Jeannie Cimiotti. Dr. Cimiotti is a professor at the Nell Hodgson Woodruff School of Nursing at Emory University. She is a longtime Watch USA member and has published groundbreaking research regarding the importance of nursing, patient safety, and the working environment. Her presentation tonight is regarding nurse retention and promotion of the workplace environment. Dr. Cimiotti, the floor is yours.
Thank you, Kevin. It's such a great pleasure to be here and to know that there are nurses that have joined and are always zooming in on your meetings, because this is really a complicated issue. It really is, the whole nurse workload outcomes relationship. And I'm just going to present some of the research that I've worked on. It's been about 20 years, a little bit more, and the findings are quite the same over time. And maybe by the end of this, we can come up with some thoughts on what we can really do to rectify this whole situation. So I've looked at nurse staffing in a number of different ways that I'll go through. I've looked at mortality and failure to rescue, and failure to rescue, it's a term that's often used in health services research, but not always fully understood. And failure to rescue is death from a complication that's missed. Something's missed in care. The patient shouldn't have died, but they did. That's what we've always called failure to rescue. And typically, I think the metric has changed a bit, but originally it was just for surgical patients because they shouldn't have complications and die if you're going in for general surgery, as opposed to medical patients, which could be much more complex. So I've had the opportunity to work with a number of lead investigators and using large samples, and I've surveyed so many nurses over the years that I can't even begin to tell you. And we could sit down and have coffee and just kind of laugh at what we've done to try to get nurses to complete surveys. But what we found out, and we find it over and over again, is nursing matters. And in this specific publication that was in medical care, we had data from nurses working in 665 hospitals in 4 states. And we found that reducing the number of patients assigned to each nurse, so even one, was associated with lower 30-day mortality and lower rates of failure to rescue. And that the benefit occurred primarily in hospitals where nurses also had a good work environment. So this is where it gets kind of tricky trying to figure out, we have to try to determine at the end that, yeah, staffing matters. It certainly does. But there are a lot of other factors that kind of feed into that. And if we aren't able to address all of them, then we run into some issues. So I think it's something that we have to think about. And, there's 5 million of us, of nurses in this country. And I think it's important to remember that since COVID, there's been a big shift in the demographic composition. And I mean, years of work of nurses. They're much younger than they were. Epic came out with a report after the pandemic, maybe 2022, 2023, and they found that a huge proportion of nurses have less than 1 year experience, and that the average tenure of a nurse, I believe it was 2.7 years of experience. So for those of you on the call that are nurses, there's a lot of learning to do when you're on that unit for the first 2 years. And so we've got struggles as a profession, but I think there are things that we can overcome. The California staffing mandate, now that's been in effect for quite a few years now. I think it was fully implemented in 2005, but I think the legislation was passed in the late 1990s, if I recall. But anyway, we decided we were going to survey nurses in California because I was at the time at the University of Pennsylvania, and we've already been surveying nurses in Pennsylvania, and we had a colleague in New Jersey, and we said, come on, we're going to survey all these nurses. And we actually sent out surveys to 250,000 nurses. I don't know how we thought we were going to get them all to answer. And I felt like I was living at the post office trying to get these surveys out and returned. But anyway, we found out that when we surveyed these nurses, and we had responses from 22,336 nurses answered this survey. And we used this California staffing ratio like a natural experiment. Okay, hey, all of a sudden now we have a state that has a regulation that says they have a specific number of nurses per unit. And we actually found that nurses in California cared for 1 fewer patient on average compared to New Jersey and Pennsylvania nurses, and 2 fewer on med-surg units specifically, because we were also looking at ICUs. And you should know that I've worked on a team with my primary person in these studies was Linda Aiken, and she has a really powerful, she's retired now, but a powerful research center at Penn. Our statistician was from GAO, and we had other analysts. So everything was really tightly controlled. But we found that if New Jersey and Pennsylvania hospitals staffed according to the California ratios at this time, and of course this was 2006 then, that there would have been almost 14% fewer deaths in New Jersey and almost 11% fewer deaths in Pennsylvania hospitals. And when we looked at the workloads and we matched them to California mandates across the states, we also found out that nurse burnout and job satisfaction were lower and consistently better quality of care in California. And if we could meet those ratios, we would also have better care. We kind of used this as a natural experiment at the time because they implemented those ratios completely in 2005. So this was 2006. And nurses were eager to tell us their story. And in another study that we did, this was with my colleagues here at Emory, we were looking at sepsis. And again, we had large amounts of data. We had data from 1,958 hospitals and 702,140 Medicare beneficiaries with sepsis. So what's happening with sepsis? I mean, because sepsis is a killer. We found 26% of these people died if they were septic, these Medicare beneficiaries. 26%, that's high. On average, mortality is 1% in an acute care hospital on a med-surg floor. But with the sepsis, when we looked at people just with sepsis, mortality was 26%. And we found that each additional hour per patient day of registered nurse decreased mortality, 60-day mortality, by 3%. And that might not sound like much, but heck, if we save one life, that's a life. 3% of 702,000, we're still talking big numbers, but if you save one life, to me, that's important in itself. And even when we adjusted, because like I said, we had some great statisticians, so we adjusted for the hospitals, the type of hospital, the number of beds they had, the number of physicians, and everything else you could think of in a hospital that we could get data on, and their structural characteristics and the case mix. And still, after all of that, just adding one additional hour of nursing care per patient day was associated with this decrease in mortality among sepsis patients. And another, we keep going on and on. We were looking at sepsis and the SEP1 bundle in another study. And we found again that in this type, each additional patient added to a nurse's workload was associated with a 12% increase in the likelihood of an in-hospital mortality among hospitalized patients. And that each additional patient, just one, added to a nurse's workload was associated with a 7% increase in the likelihood that the patient would be readmitted in 60 days. And that these associations were persisted, even accounting for the SEP1 bundle. Sometimes I look at these numbers and I look at them again and it's like, I can't believe this happens, but it does. And if you're a nurse, you can see why people are readmitted. And especially when you're overworked. Who has time to sit there with the patient and explain everything to them when they're leaving? Admission and discharge are two important things that nurses do. That's where you're likely to miss information, especially the discharge. If you're rushing, a good discharge, you shouldn't have people coming back. You shouldn't have patients coming back. It should be rare, a rare event, but yet it happens. And I think that's where the issue comes into play, is that we're rushing through a discharge. We also had another study where we were looking at sepsis, and this was a different sample, and this one was across multiple states. You can see there: California, Florida, New York, Illinois, New Jersey. 537 hospitals. And again, each additional patient, that's just one patient per nurse, was associated with a 9% increase in the likelihood of 30-day mortality, 10% increase in the likelihood of 60-day mortality. And again, each additional patient per nurse increased the odds of readmission by 78%, and ICU admission by 12%, and length of stay by 10. And each 10% increase in the SEP1 bundle compliance was associated with a shorter length of stay, but not with the others. So if you follow sepsis, there's a lot of controversy around the SEP1 bundle, if it really is doing the job that it should do, and that's improve outcomes. And compliance with the bundle is poor. We found that compliance with the sepsis bundle was about 56%. So people can't comply with it because it's an all or nothing metric. I can't remember all the components to it, but it's antibiotics, fluid, maybe vasopressor and something else I can't, but it's all got to be like within an hour or something. And if you miss one component of that, then you don't meet the bundle. So I think that's an area for more work on sepsis and how we treat sepsis. And maybe there's a better alternative than that SEP1 bundle. But what we see in adults, we also see in children. And I was actually trained as a pediatric nurse, and the things I saw happen, I wouldn't wish anybody to see. Adverse events, because it's difficult enough as a nurse to witness harm to an adult. But when you witness harm to a baby or a small child, it's like a knife in the chest. But anyway, we found out that when a nurse had every patient above 4, so if a pediatric nurse had more than 4 patients, there was 11% higher risk of 30-day readmission for children hospitalized with medical conditions. And for children recovering for surgery, each additional patient added to the nurse's workload was associated with a 48% higher risk of readmission. That's huge. Nurse practitioners. We've done some work with nurse practitioners. There's a lot of talk about nurse practitioners now, and can we bring more of them into primary care, especially in the rural areas where we're lacking providers. But this was acute care nurse practitioners. And we found that in hospitals with 3 NPs per 100 beds had 24% lower likelihood of 30-day mortality than hospitals with fewer than 1 or 1. And that hospitals with more NPs also had lower odds of 7-day readmission. And that the patients and nurses, that meaning the bedside nurse, in higher NP ratio hospitals reported better quality of care and better safety. And the staff nurses reported lower burnout and higher job satisfaction. And in my time being a acute care nurse, especially when I was in the PICU, pediatric ICU, back then we actually had more CNS, the clinical nurse specialist, which I think as a profession, we really kind of threw them under the bus because the CNS did such a great job. And when I'd be in a peds ICU, we'd have a new diabetic and you had an endocrine CNS on the floor. I mean, that was like the heavens opening up when that person would walk on the unit. I don't know how I really got interested in healthcare associated infections. Well, I know how I got interested in them. I don't know how I got interested in infectious diseases, but maybe it's because I'm an alarmist. I can remember working in the ICU in New York. Then it was Babies Hospital. Now it's New York Presbyterian Children's, Morgan Stanley, whatever it's called. But I remember them saying somebody was going to go to the Bronx Zoo with their kids. They said, don't go to the Bronx Zoo. The birds are all dying. And they think I'm nuts. They said, don't go to the zoo. I said, there's dead birds everywhere. And maybe Kevin remembers this, but that was the first cases of West Nile virus. It came with all these dead birds they found at the Bronx Zoo. And it wound up being West Nile. So I don't know. I've always just had this thing about infectious diseases. And it wasn't until I went to graduate school and I had the opportunity, this was working on a PhD, to have work on a research study. Then I realized the importance of healthcare associated infections because that's what they were working on. And I was actually fortunate enough to be on a clinical trial, one of the first where we were trialing alcohol-based hand sanitizers versus surgical scrub. And the interesting thing was they kind of both performed the same and that they really didn't see any improvement by using the alcohol, which they thought they would because it would be more convenient to use. And there was no decrease in infections with the use of the alcohol hand sanitizer versus the surgical scrub. The only thing we found, and this was not even part of this big study, it was a huge research study going on there. The only thing associated with those infections was the number of nurses on the unit. And nobody even noticed it. I was collecting the data. I said, no, wait a minute. Look at this. Look how these units are so different, the way they staff. And that was the only thing in this multi-million-dollar study that really was associated with the infections. It was the staffing. But not to make things a little more complicated, it's not just staffing. It's just multifactorial. And we have to find the root causes and rectify those. And it's going to take a team of us to really fix this. But I happened to work on a study in Pennsylvania. It was the only state at the time that was collecting healthcare associated infections, and they had a reporting system. So I was able to get those data, and we had survey data from 7,076 nurses And we had this infection data on the 161 hospitals. And we found that, first of all, these nurses, a little over a third of them, were reporting high emotional exhaustion, which is one of the components of burnout, which was surprising because analytically, for those of you that know much about statistics, nurse staffing was significantly associated with these infections. However, once we put it into a full model, which you want to do at the end, you want to control for any other kind of factors, nurse staffing no longer was significant, but burnout was. The nurse burnout, and it was associated with urinary catheter infections, or CAUTI, and surgical site infections. And we saw that each 10-point increase in the rise of high burnout nurses was associated with 1 additional UTI and approximately 2 additional SSI per 1,000 patients annually. And we had our statistician run models that if we could reduce the burnout by 30%, what would happen? And we found out that we would reduce the infections by 6,239 in 1 year and save up to about $68 million. I don't know, every once in a while, for those that publish a lot of papers and such, once in a while you'll have one that kind of is like hits the home run, and this was it. I don't know why, but it did. It was in the American Journal of Infection Control. It was on the front page of the Philadelphia Inquirer. Well, we were in Philadelphia, so that didn't make sense. It was on the front page of the Daily News in the UK. I have a file of probably about 50 or 60 news outlets across the world that had this paper that they had cited in their press. And one of my mentors at the time said, "What is it about this paper?" She said, "We do a lot of papers on death and mortality. None of them bring this kind of press in." And I said, "It's got to be the money, because we never talked about money before. It was always just the numbers. And sometimes, especially in the United States, where healthcare is a business, money, when you start to talk money, people tend to listen." I have a video on the next page, and it was just, somebody sent me this, and it almost blew me out of the water, because I thought, what is this group now? Because this took off like wildfire. Let's see if I can play it.
From Philadelphia, new research in the American Journal of Infection Control has found that nurse burnout and their patient load is associated with an increased number of healthcare-associated infections. Using a survey to measure job burnout of over 7,000 nurses in Pennsylvania, the researchers found that for each 10% increase in a hospital's high burnout nurses, there was 1 additional catheter-associated urinary tract infection and 2 additional surgical site infections per 1,000 patients every year. Over 1/3 of the nurses surveyed met the criteria for healthcare burnout, and they estimate that reducing this rate down to 10% would prevent over 4,000 infections per year, and also eliminate the associated monetary costs of these infections, estimated to be $41 million for Pennsylvania hospitals.
I don't know how this thing, it just exploded, but I think it's the money. When you start to talk to about money, people have a tendency to listen. Unfortunately, they don't necessarily want to listen to us nurses, but they'll listen when they see money. Another thing, we also looked at MRSA, and we had hospital onset MRSA rates for 2020 and 2021, and we found that each additional RN hour per patient day was associated with a 3% decrease in the rate of hospital onset MRSA infections. Same thing with C. difficile. We had a survey from 15,982 nurses across 353 hospitals, and we merged it with Hospital Compare C. diff. We found that 188 of those hospitals, or 53%, had a standardized infection ratio, or an SIR, higher than the national average. And hospitals in the upper quartile for all nurse and work environment scales, so staffing, support, all those other important environmental factors, had a significant, if they were up in the higher ranking of that scale, had lower odds of above average infection. This was one of the first studies I was involved in the neonatal ICUs in New York City, where we had the data on 224 infants, and 8.4% developed a healthcare associated infection during that time. It was the same thing. They didn't know. This was the surgical scrub and the alcohol gel they were looking for, and nothing came to fruition with those. But we did find that each additional hour of registered nurse care per infant was significantly associated with a 79% lower risk of a bloodstream infection. And that's important because these babies died when they got a bloodstream infection. Mortality was really high. You're talking about babies that might be 2 pounds. They're tiny. They're the NICU babies. So they're at really high risk. And increasing the registered nurse staffing by 1 FTE was estimated to reduce the bloodstream infections by 11% across that unit. Again, like I said, the cost, I think it's the cost that's really a big driver that's bringing a lot of attention to the staffing. And they'll tell you that it's going to cost them too much money to improve the staffing. But I think we've got something going on right now at Emory that I know that's going to prove that otherwise. This was another study we had that we showed that, again, this was from 2018 data from 2,107 hospitals and almost 654,000 Medicare patients. But each 1 unit increase in RN hours was associated with a 2% shorter stay. Each 1 point increase in RN skill mix, meaning more RNs. The skill mix is a higher proportion of RNs compared to RNs and LPNs and aides, was associated with a 1% shorter stay. Raising staffing to 9 RN hours per day and an 80% skill mix, so that means 80% nurses and other staff, could save 63,580 inpatient days or $152.9 million annually. And if you upped the number of RN hours to 11 and increased the skill mix by another 5%, you could save a little over $331 million annually. Just keep an eye out. We have one under review at Annals for Surgery. Couldn't ethically, I guess, provide the data yet, but it's under review and it's similar. We found that nurse workload was associated with postoperative pneumonia, which makes sense. But post-op pneumonia, we need the nurses to be able to get the patients out of bed and ambulate them. If they're too busy, who's going to worry about getting the patient up to walk? You know, it kind of makes sense. If you're a nurse, you'll understand it. You just can't do everything. And walking a patient isn't a priority when everybody else is crashing or something. It makes a lot of sense to me. So we're waiting to hear on that. Burnout, it's huge. These were data from 2017, where 31.5% of nurses who left their job cited burnout as a reason. Look at how it increased from 17% 10 years earlier. Nurses leaving or considering leaving due to burnout have cited a stressful work environment, and that's 68.6%, 59.5%. And among the same groups, inadequate staffing is even higher reason for them quitting at 63 and 60.9%. This was only a small study with only 182 participants, but it makes us start to think a little bit different. There were 182 nurses, and 131 of them, or 72%, reported some degree of financial hardship. And that was defined as they had difficulty paying their bills. Now, I don't know what's happening now in units, but when I was working at nurses, if they were looking for money, they'd pull a double, and that was a 12-hour shift. They worked a 24-hour shift straight, and they would take a break maybe for an hour in an empty patient room and lay down. If that's still happening, I don't know. I mean, I don't know if somebody's in the hospitals now to know. That's got to stop. I mean, that's when things would go. In fact, anytime I saw a nurse work past that 12-hour mark, things went bad. When they started approaching 14 hours or 16 hours, everything kind of spun out of control. Anyway, what we found in this study is after you adjust for all their demographics and workplace and everything else, financial hardship was significantly associated with higher burnout and higher secondary traumatic stress. And that financial hardship was also linked to lower compassion satisfaction. Some of this work has caused Emory to increase the salaries of their nurses across the board. Workforce retention, the economic value, the retained framework. You're going to see this coming. I mean, this is in the literature already. This is taking off. This is actually the work of one of my mentees. He just graduated in May with a PhD, already has his own company. He has a whole platform that he's developed on how to help nurses. He was a brand new COVID nurse and quit nursing after 6 months and was determined that he would make it better for every other nurse that ever came on a unit. And as he has done it, he came across all this. So what he did was he created this retained framework. He did process mapping to examine nurse turnover, to determine every little point, what happened during that continuum before a nurse quits. He did cost accounting. He did analytics and staffing on backfill strategies and how much was the financial trade-off for bringing in contract nurses. And he actually created this executive dashboard. And based on this research that he did, this is his dissertation research, that Emory gave all their nurses across the board a sizable increase, and they're saving money on top of everything else. So what he showed them was, he talks the business case. So the cohort experienced a 24% turnover rate in 2023, with 360 people leaving. Vacancies, he said, took on average almost 22 weeks to fill, and 75% or a little more were covered by contract labor. That's your agency nurses, which is hugely expensive. When backfilled by contract labor, per nurse turnover cost reached almost $86,000. And the total annual system-wide turnover cost was almost $23 million. I just want to let you know that I'm kind of tying this up now. We have a grant under review to look more at sepsis, and this time we're going to be looking at the nursing notes to see if we can pull something from the nursing documentation that explains the sepsis outcomes better than just staffing and like, what do the nurses have to say? And we're working with our colleagues at Mass General in Boston on this grant, and hopefully it'll get funded. And that's it. If there's any questions, I'm your nurse here to answer whatever you might like.